I'm doing this session. So while I'm doing the session, if you have any questions, please don't hesitate to ask in the chat or reach me out on my email or on my phone number. Okay, so let's start with the learning objectives. Number 1, describe the mechanisms of electrolyte transport in the jejunum, ileum, and the colon. Explain the mechanism of chloride secretion in the large intestine and name the neurotransmitters that can affect it. So for this, we have VIP and ACH. Describe the mechanism of fluid retrieval from the GI during hypovolemia and the effects of RAAS, the renin-angiotensin-aldosterone system. And then we have described the mechanism by which cholera toxin is causing secretory diarrhea. This is very, very important. Describe the mechanisms of iron and calcium absorption and then vitamin absorption. Right. So let's talk about isotonicity. What is isotonicity? This is when two solutions have the same concentration of solutes. In this case, we're going to talk about blood and chyme. Initially, when the fluid osmotic pressure gradient, okay, the intestinal water movement is driven by osmotic pressure gradients, and the fluid that is entering the duodenum is very hypertonic, means there's very less water inside the chyme. So water moves from the blood into the lumen. Okay. Now, the fluid could also be hypotonic, and the reverse has 60 minutes in the proximal jejunum. Now, if you guys remember, okay, let's go back. Okay, so now if you guys remember, we have the stomach initially, okay, and then we have the duodenum, okay, then we have the jejunum, and then we have the ileum. This is how it goes. If isotonicity is achieved in 30-60 minutes in the proximal jejunum, this is going to be over here, right after the duodenum, okay? So after the proximal jejunum, you're going to have the rest of the jejunum, and you're going to have the ileum. This is where you're going to have bidirectional flux. What is bidirectional flux? This is when you have water movement in two directions. You have it into the lumen, and then you have it into the plasma, okay? If we look into the microstructure of the small intestine, you have a brush border, okay, which consists of these elevations called villi. So these are the villi. And then you have these depressions called the crypts. Now, the elevations, which are the villi, the cells inside of the villi are absorptive, and the cells in the crypts are secretory, okay? And when you have bidirectional flux, this means that electrolytes are continuously being absorbed by the villi, and they're continuously being secreted by the crypt, and water is going to follow. So you're going to have two movements continuously. But if you're going to have two movements, which one of these is going to have the upper hand? This is found by net absorption, or net flux, basically. And in normal physiological conditions, you're going to have net absorption. So, for example, absorptive flux is 2.2 milliliters per minute, and secretory flux is 2 millimeters per minute. So 2.2 minus 2 is going to give us plus 2, which is net absorption into the plasma. So this way. Next, we're going to talk about the sodium-potassium pump. Now, this is going to basically be the most important thing in all of the small intestine and then up to the colon, okay? Let's orient ourselves. We have the interstitium over here, and then we have the lumen over here. This side, this is the basolateral membrane, okay? And this is the apical membrane. So on the basolateral membrane, you have the sodium-potassium pump. 3 sodiums are going to be pumped out of the cell, and 2 potassiums are going to be pumped into the cell. Now, if you notice the discrepancy, if you're going to pump 3 sodiums outside of the cells and 2 potassiums inside, and both are positive, you're going to have more electronegative charge inside of the cell. This is going to create an electrical gradient over here. And then sodium and potassium are 2 different ions, right? So it's also going to create a chemical gradient. Now, of course, when sodium is going outside of the cell, there's going to be less sodium inside of the cell, okay? And all the sodium in the lumen is, of course, going to go inside of the cell. So you're going to have a driving force or a gradient for sodium absorption. And then another driving force for secondary transport systems, like co-transporters or exchangers, okay? So you're going to have co-transport of glucose, amino acids, galactose, hydrogen ions, and all those things. Okay, this is the written version. You can read through it by yourself. This is what I explained just now. So the jejunum. Now, this is very important. In the jejunum, you have net absorption of sodium hydrogen carbonate. Okay, so let's draw it out. We have the cell. This is the epithelial cell. We have the interstitial. Okay, so the sodium is going to enter the cell via the sodium glucose or galactose cotransporter, or the amino acid cotransporter, or the hydrogen exchanger. Okay, so you have sodium inside of the cell. The hydrogen is going to go out of the cell into the lumen. Okay, so sodium is coming inside the cell, hydrogen is going to go outside of the cell. Now the question is, where does the hydrogen come from? If the glucose and the galactose and the amino acids are coming from food, where would the hydrogen come from? Carbonic anhydrase. Now, the hydrogen comes from intracellular carbonic acid, which dissociates into hydrogen and hydrogen carbonate. Hydrogen carbonate is formed by the reaction of intracellular carbon dioxide and water, catalyzed by the enzyme carbonic anhydrase. So this is the reaction. Carbon dioxide plus water gives us carbonic acid. Okay, and this is going to dissociate into hydrogen ions and hydrogen carbonate. The hydrogen ion is going to be secreted into the lumen via the sodium hydrogen exchanger, and the hydrogen carbonate is absorbed back into the blood across the basolateral membrane. So in this case, this is the diagram. We're going to have sodium and hydrogen carbonate absorbed into the blood in the jejunum. This is the net result. Okay, then we have the ileum. Over here, we're going to have net absorption of sodium chloride. Sodium, again, is going to enter via the glucose and amino acid cotransporter and then the sodium hydrogen exchanger. Okay, so it's the same mechanism. Once again, you have the epithelial cell, you have the interstitium, and you have the lumen over here. Okay, sodium is going into the cell and hydrogen is going out of the cell. Okay, this is the reaction, just the same as before. But in this case, the hydrogen carbonate, which was absorbed into the blood in the case of the jejunum, is actually not going to be absorbed into the blood in the case of the ileum. Why is this? Okay, so let's read. Hydrogen carbonate formed inside the cell from CO2 and H2O is secreted into the lumen via the CO, which is the chloride HCO3 hydrogen carbonate exchanger in the apical membrane. Again, you have the cell, you have the interstitium, and then you have the lumen. The hydrogen carbonate is going to go out into the lumen, and the chloride is going to go into the cell. Okay, so in this case, you're going to have chloride moving into the cell and then out into the interstitium. CO exits into the blood across the basolateral membrane, chloride transporter. Okay, so in this case, you have sodium moving into the interstitium, and then you have chloride moving into the interstitium. This is a diagram. Let's go through it one more time. This is the sodium hydrogen exchanger. So you have sodium going into the cell, and you have hydrogen going outside the cell. Okay, the hydrogen carbonate that was formed in the carbonic anhydrase reaction is going to go out of the cell. And exchange, you're going to have chloride from the lumen go into the cell and then out into the interstitium. So then you have NaCl in the ileum. All right, this is the diagram from Dr. Angelica's slides. I hope this is clearer now. Okay, so then we'll move on to the colon. We're done with the small intestine. Now we have the large intestine. Let's draw it out one more time. Or actually, let's go to the diagram. Look. Here we have the epithelial cell of the colon, and then you have the blood, and you have the lumen. Okay? This is a sodium channel, and this is a potassium channel. This is the sodium-potassium pump, the primary active transport pump. Okay? Guys, am I lagging? Am I audible? Okay. All right. So sodium channels over here. Sodium is going to be absorbed into the cell, and then potassium is going to be secreted out of the cell. So when sodium is absorbed into the cell, it's going to go inside of the cell and then go through this sodium potassium pump out of the cell, and then potassium is going to go inside the cell. So we have this sort of gradient going on, right? Aldosterone is going to increase the expression of the sodium channels. And when it does that, if you have more of these sodium channels, for example, 1, 2, 3, 4, more of the sodium is going to go inside. And when more sodium is going inside the cell, it's going to go through this ATP pump outside. So this thing is going to work overtime. And then more potassium is going to go inside the cell. And then in the end, you're going to have a lot of potassium being transported across the membrane as well. If that is going to happen, we're going to have a lot of potassium inside of the lumen over here. So in the lumen, when you have a lot of potassium, it's going to be washed away. High flow rates, for example, in diarrhea, increase potassium secretion. So if you have a lot of water flushing through your small intestine and then through your large intestine, it's going to cause an increased potassium secretion. This occurs because faster flow enhances the gradient for potassium efflux into the lumen. So diarrhea often leads to potassium loss, causing hypokalemia. So if somebody comes to the clinic with weakness, headaches, low BP, muscle cramps, one of the potential causes could be hypokalemia. I hope this is clear. Then we'll move on to crypt secretion. Okay. So we established that we had these thingies, okay, and these are the villi. And then we had the crypts over here. The crypts are where secretion is possible. So secretion is the secretion of basically electrolytes from the interstitium into the lumen. So how is this going to happen? Let's start with this diagram. You have the interstitium here and you have the lumen over here. First of all, you're going to have a secretagogue. What is a secretagogue? It is a substance that stimulates the release of another substance. Okay, so in this case, we're going to have vasoactive intestinal peptide. This is going to stimulate adenyl cyclase and increase cellular AMP, okay, CAMP. Cyclic AMP, sorry. And when you have an increase in cyclic AMP, this is going to activate the CFTR, which is a chloride channel. You don't need to know the full form of the name. It's not mentioned in Dr. Angelica's slides. So this chloride channel is going to move chloride from inside of the cell to outside of the cell, like that, okay? So you're gonna have an accumulation of chloride ions in the lumen, very negative, right? And there's a lot of ions, it's gonna become hypertonic. So you're gonna need more water in the lumen. How is this going to happen? Sodium is going to move from the interstitium to the sodium moves, water also moves. So the water is also going to move with the sodium to the lumen. This is going to create logical gradient that we had established before. Okay, this is the other one. Okay, so we said that chloride is going to accumulate in the lumen, right? But then if chloride is going to go into the lumen, there's going to be less chloride in the cell, and we need to basically have lots of it, right, to maintain the CFTR channel. This is where the sodium potassium 2Cl negative cotransporter comes in, okay? Let me just clear this out. All right, let's look at it one more time. Into the cell so that we can maintain this CFTR channel working. So this is called the sodium potassium chloride cotransporter. It's basically like a tri-ion transporter. So it's going to move a potassium and a sodium and 2 chlorides into the cell. And that is going to maintain the gradient for the CFTR channel. This is, of course, the VIP is released in response to irritation. And this is a very transient effect. It's not permanent. And once the irritant is washed away, the VIP is going to detach and you're going to go back to normal. But if it's like if the irritant doesn't go away, or if it's like in the case of cholera, for example, like cholera toxin, this is going to cause diarrhea because Cl is going to be continuously released into the lumen, and then sodium and water are also going to move into the lumen, and it's just going to keep happening, right? And that's going to cause diarrhea in the colon. This is another diagram that we have. Basically, again, increase in CAMP opens apical anion channel, and then increased activity of basolateral sodium potassium chloride cotransporter. And yeah, this is basically the explanation for this. I hope this is clear. Checkpoints. Okay, so in which part of the small intestine is hydrogen carbonate mainly absorbed into the blood across the basolateral membrane? Is it the duodenum, the jejunum, or the ileum? Okay, so the answer is jejunal, because in the ileum, the thing that is mainly absorbed, according to the slides, is sodium chloride. So in the jejunum, it's sodium hydrogen carbonate. Next, we have hypovolemia. Now, when you have hypovolemia, you have a loss of fluid inside of the blood. So your blood pressure drops. And you also have a decrease in the extracellular fluid. This can occur due to, of course, a hemorrhage, which is like one of the primary reasons. Blood loss reduces circulating volume. You could also have plasma loss because of burns, GI losses if you have profuse vomiting, diarrhea due to cholera toxin or whatever reason. Sweating, you're going to have fluid and electrolyte loss. Renal losses, excessive urine production in diabetes, and then, diabetes insipidus or uncontrolled diabetes mellitus, basically diabetes. These losses reduce blood volume, triggering compensatory mechanisms to restore volume. That's going to include your sympathetic nervous system and your renin, angiotensin, aldosterone system. Okay, so let's talk about RAAS. So hypovolemia is going to trigger the RAAS system. The kidneys are going to release renin. They're going to sense the hypoperfusion. They're going to sense the low blood pressure, and they're going to release renin, which catalyzes the conversion of angiotensinogen into angiotensin 1. Okay, don't make the same mistake I did. This is angiotensinogen into angiotensin 1. Angiotensin 1 is converted into angiotensin 2 by the enzyme ACE. ACE is angiotensin converting enzyme. So all of that, and we're left with angiotensin. This is very important. Angiotensin promotes the adrenal glands to release aldosterone. Okay. Now, we just talked about aldosterone before. We're going to come back to it. Angiotensin 2 enhances SNS activity, which is the sympathetic nervous system. Okay. Now, as we talked about it before, aldosterone is going to increase the expression of ENaC, which is epithelial sodium channels, on the apical membrane. Okay. And that is going to, of course, increase the absorption of sodium into the cell, which is going to promote the secretion of potassium and cause hypokalemia. Just talked about this. Compensation. So we're going to have compensation in 2 areas. We have the small intestine and we have the colon. Okay. Let's talk about the small intestine. Hypovolemia triggers baroreceptors in the blood vessels to signal the CNS, central nervous system, sympathetic centers, spinal cord, nucleus, intermediolateral, IML. This is mentioned in your lectures. Make sure to know this. The sympathetic nervous system enhances fluid reabsorption by increasing the activity of sodium transporters, which help retain water in the small intestine. Okay, this is just learn this word by word. Then we have colon. The RAAS system is triggered by hypovolemia again. Kidneys are going to release renin. We just discussed this before, renin, and then angiotensin 2. Angiotensin 2 prompts the adrenal glands to release. Sodium reabsorption in turn draws water passively, contributing to fluid retention. This is also very, very important. Okay, then we're going to talk about the minerals and the electrolytes. First of all, what are minerals? You have sodium, you have potassium, calcium, all these little ions, iron. So these are not digested, okay? And especially iron and calcium, they're absorbed according to need, okay? The rest of the minerals are absorbed at constant rates, regardless of need. So we're talking about sodium and potassium and so on. Okay. So iron absorption. This occurs primarily in the duodenum. Okay. You ingest two forms of iron. You have ferric iron from vegetables. You have ferrous iron from meat through your cells. If you sit to the ferron, 3 plus ferric to Fe2 plus ferrous. Okay, and for this you need HCl and vitamin C. Now, how would HCl and vitamin C help in iron absorption? HCl is hydrochloric acid, okay, mainly from the stomach. It provides an acidic environment, facilitating the conversion of Fe3 plus to Fe2 plus via duodenal cytochrome B. And vitamin C is basically the reducing agent. It provides the electron that makes Fe3 plus go to Fe2 plus via the same enzyme. And then we have DMT1, which is the divalent metal transporter 1. It's going to basically absorb the ferrous iron from your lumen into the cell. And the iron, Fe2 plus, is stored in all cells, but primarily in hepatocytes. These are the liver cells, hepatocytes. And they're stored with combination to apoferritin. So there's this molecule, basically, it's called apoferritin. And once it combines with iron, it becomes ferritin, and that is how iron is stored inside of the cells. Now you may ask, why do we need to combine it with apoferritin? Because there's this thing called the Fenton reaction, and if you basically have like free iron, it's going to cause the generation of harmful disease and be like degradative inside cells and not basically. It's stored as ferritin. And then we're going to talk about ferroportin. This is ferritin stored as iron stored as ferritin here. Then we have ferroportin. If you want to move iron from inside of the cell to the blood, you're going to have to move it through this molecule. Okay, so iron has to go through ferritin in the bloodstream. You can't move around the bloodstream. You just can't. So you have to bind it to this molecule called transfer. Okay, it's sort of globule and the iron, and that is the duodenal cytochrome B, Fe3 plus to Fe2 plus. Okay, hope this is clear. This is from your slides. We have, okay, heme is totally different, by the way. Heme is a combination of porphyrin and the red blood cells. It's basically like the thing that binds, the molecules that bind to oxygen, okay? So heme has its own transporter, and then iron has its own transporter, which is DMT1. Just know that. Okay, then we move on to calcium absorption. For calcium absorption, you don't need to know much right now. You're going to learn more in the next box. First of all, you have paracellular. This is not regulated. This is bulk transport. Okay, it is like between the cells. So you have like 1 cell, 2 cell. It's like kind of gonna go sneak between the cells to the interstitium, okay, or blood. And then you have transcellular. This is when calcium is going to move through the cell. So of course, when it's going to move through the cell, it's going to involve some receptors, and some channels and whatnot, and that is regulated by vitamin D3. Vitamin D3 increases absorption of calcium in the GI and the kidney. Okay, you're going to learn more about this later. Now, why is calcium important? Why are we learning about this? Because calcium is, of course, involved in the formation of your skeleton, your bones, your teeth, your blood clotting factors. It's like the secondary messenger. And then, like for exocytosis, you have influx of calcium in various cases. So you need calcium. It's very important. This is from the slides. Paracellular absorption is not regulated. Transcellular transport is regulated by vitamin D3. Then we have, okay, so in the slides, we had like this paragraph about the individual parts of the small intestine, the duodenum and the jejunum and the ileum. So I put them into separate slides for you. In the duodenum, you have absorption of iron and calcium. Okay, and then you have absorption of water-soluble vitamins. We'll come back to the vitamins in a sec. Then you have the jejunum. You should like kind of learn this word to word. This is very important. In jejunum, 50% of sodium and same amount, about 50% of the water is reabsorbed, as well as chloride, potassium, and hydrogen carbonate. The mechanism is similar to the PCT, proximal columnar tubule of the nephron. Then you have the ileum. In the ileum, absorption of bile salts and B12, which requires intrinsic factor. Okay, so basically, you have absorption of these things called bile salts and vitamin B12. And vitamin B12 especially requires intrinsic factor. Okay, intrinsic factor is secreted by the parietal cells of the stomach. Okay, so if you like just resect the stomach out of the body, you're not going to have any secretion of intrinsic factor. And if you resect the ileum out of the body, that's where B12 is absorbed. So in both cases, you're not going to have any reabsorption of B12. And that is going to cause things like pernicious anemia or megaloblastic anemia, because this is a very important vitamin involved in formation of red blood cells. So I don't think you need to know the details for this, but just know that it can lead to anemia. And then you have net secretion of hydrogen carbonate in exchange for chloride. We just talked about this. Please make sure to go over the slides very carefully, especially for the net secretions. Okay, they're very important. Then we have the colon, or the large intestine. Here you have limited net absorption of the electrolytes, sodium, chloride, potassium, and water in the ascending and transverse colon. Then you have net secretion of hydrogen carbonate and potassium. And the colon is the most efficient in conserving electrolytes. And we just talked about the aldosterone thingy. So when you have like a lot of aldosterone, you have a lot of absorption of sodium and a lot of secretion of potassium. That's going to cause hypovolemia and increased flow rate like diarrhea. Colon loses a lot of potassium this way. These are some important points that you need to focus on. Majority of the water is reabsorbed in the small intestine, and then the cholera toxin mechanism. Okay, I think we should go back to that one more time. Okay, right over here. So you just clear this out for you. Do you see this VIP over here? This is a vasointestinal peptide, right? Now pretend this is the cholera toxin, okay? What the cholera toxin is going to do is that it's going to activate the adenyl cyclase again, okay? And that's going to cause an increase in CAMP. When you have increase in CAMP, again, we're going to have CFTR activated and Cl negative is going to go into the lumen, okay? It's the same mechanism again, except that it's not VIP, it's the cholera toxin this time. So just make sure that you know this very well, because this is very high yield, okay? And then we have role of HCl and vitamin C in iron reabsorption. So we just talked about this. Hydrogen chloride provides an acidic environment, facilitating the conversion of Fe3+ to Fe2+, and vitamin C is a reducing agent. And both of these involve the duodenal cytochrome B, okay? aldosterone in the colon, we just talked about this. Sodium-dependent co-transport for water-soluble vitamins in the small intestine. Okay, so you remember how we had the co-transporting molecules in the apical membrane? We had sodium going inside of the cell, and then we also had glucose or amino acids or galactose going inside with the sodium. Just like that, you have it for the water-soluble vitamins. So what are the water-soluble vitamins? Let's talk about it. So let's start with sodium. I'm going to clear out the screen. Just give me a sec. Okay, so let's start with sodium. Absorption by sodium channels, co-transport with amino acids, glucose, chloride, and sodium hydrogen countertransport. And then you need to know the role of aldosterone in the colon. Then we have the chloride ions. We have sodium chloride co-transport, chloride hydrogen carbonate countertransport. Chloride is also secreted into the lumen, camp, and chlorotoxin. So we just talked about this. Chloride is very, very important. You need to know the mechanism by heart because it's probably going to come in the exam. Then you have potassium. Absorption in the small intestine passively via paracellular routes, and then secretion in the colon via aldosterone, not by aldosterone, but because of the effect of aldosterone on the sodium channels, which can cause diarrhea. Okay. Sorry, not cause diarrhea, which increases in diarrhea. Okay. Then we have vitamins A, D, E, and K. Now, these are lipid soluble and taken up in mast cells in the small intestine. Mast cells are basically like these phospholipid envelopes. It's hydrophobic, so that you have the fat soluble or the hydrophobic vitamins inside, and then the water environment is outside, so it can easily pass through membranes or be absorbed, taken up. Then you have water-soluble vitamins, which are sodium-dependent co-transport in the small intestine, the jejunum and the ileum. And then we talked about vitamin B12, which was related to anemia. This combines with intrinsic factor, and this is actively transported into the distal ileum. And then let's come to alcohol. Gastric alcohol dehydrogenase, and it is absorbed in the stomach, and the small intestine depends on the rate of gastric emptying. Okay, you want to know the details of this, just like know this from the table, basically, just the enzyme. Gastric alcohol dehydrogenase. And then water. Absorbed, basically it's by osmosis, mainly in the small intestine, which is 95 to 98%, okay? So if there's like a question in the exam, they're like, well, where is water mainly absorbed in the GI tract? Okay, don't make the mistake of or something. It's always the small intestine, 95 to 98%. Okay. In the previous lectures, like in the 16th batch, 15th batch, we had like the numbers, like the mLs, basically 9,000, 8,000. But in Dr. Angelica's lecture, you're not going to find those, so I don't think you need to know those. This is the summary. I got this from 16th batch. You have all of these exchangers and channels and their locations. You can go through these. You have the sodium hydrogen exchanger in the small intestine, solute coupled absorption is also in the small intestine, which is basically bile salts, all of that, which is in the small intestine. Excuse me. And then you have electroneutral sodium chloride absorption. We just talked about this. This was in the ileum. Forget the colon, okay? This was in the ileum, according to Dr. Angelica's slides. And then we had CFTR secretion, which is in the small intestine and colon, mainly in the colon because of cholera and toxin and all that. Okay, so small intestine for the NaCl, and then CFTR for the colon. And then solute coupled sodium absorption on the colon. And then we have the neck absorption in the distal colon. This is the aldosterone one, okay? So aldosterone, again, is going to increase the expression of ENaC channels in the apical membrane of the colon, okay? And that is going to get more of the sodium into the cell. And that is going to increase the activity of the sodium-potassium pump, which means that there's more potassium in the cell now. When there's more potassium in the cell, it's going to have to move outside of the cell again. And it's going to go through the potassium channel from the cell into the lumen. And that's going to cause water movement as well, okay? Of course, the water is going to follow. So primarily, it's also going to cause hypokalemia. It's going to be flushed out, gone. And that was the end of this PAL session. I hope that you understood everything. Good luck for your exam, and please scan the QR code for quality support. Thank you.
Nawaal, I believe they want you to go through something again.
Okay. Let's see in the chats. Can you go over through lipid-soluble vitamins? Okay. Give me a second. Okay. Oops. All right, so these lipid-soluble vitamins are A, D, E, and K, okay? They are taken up in my cells. What are my cells, basically? They're like these you know how you have the phospholipid bilayer, right? You have like the phospholipid head over here, the phospho head, and then you have the lipid tail. So the upper part is hydrophilic because you have water here. And then the lower part is hydrophobic. Why is it hydrophobic? Because you have it's a lipid bilayer, so you have another lipid chains, and then you have another. So this is the bilayer, okay? Now, pretend this is a circle. So let's make a circle over here. Okay, so this is the circle, and then you have all of these lipid tails, okay? And outside, facing the water, you have the phosphates. The phosphates are positive, negative, whatever. This is hydrophilic. And inside, it is hydrophobic. Now, these fat-soluble vitamins are, obviously, they're not going to interact with the hydrophilic area. They don't want to be near the water. They want to be inside so that they can get transported across the membrane. So you're going to have vitamins A, D, E, and K inside of these micelles. And these micelles are what's going to be like the main medium through which you're going to have the transportation of the fat-soluble vitamins into the blood. I hope that is clear. Okay, that's great. If there are any questions about cholera or aldosterone,